in a day. And that was considered the kind of the gold standard. If you wanted to know exactly how much protein was being lost, you do that. But you know, medical facilities are really reluctant to have somebody pee in a bucket for 24 hours. I don't think it's really not that terrible. I mean, there are a lot worse things that we have to put up with in terms of treatment, but it's considered a pretty heroic test. So not used a lot nowadays because we've come up with a better idea. So in 2012, when we changed the definitions of chronic renal failure to chronic kidney disease, they also came up with the idea that they would prefer to measure albumin rather than protein. In some ways, it's easier to do. It's more accurate. You actually, when you measure albumin in the urine, there's a chance that you may be missing some pathologies, that's for sure. But now the preferred method is to measure albumin in the urine. And sure enough, you can do it the same way. You collect urine for 20, and this is bottom left. Normal is less than 30 milligrams a day. Have you come across these terms? Microalbumin, I can't say it. Microalbuminuria. Yes? I'll write it up on the board then. Oh, it's in the handout. It's a long word, isn't it? All right, I'm going to do it. Microalbumin. I'm not going to do macroalbuminuria. And this would be 30 to 300 milligrams per day, and anything over 300 is macro. I'm not sure I'm excited about the terms micro and macro. To me, micro is kind of small and macro is big, but this is really micro amounts and macro amounts. This is a pretty sensitive test, and even though we call this microalbuminuria, you know what I said, meant microalbuminuria. This is particularly important in people that are being monitored for stages of chronic kidney disease. In diabetics, the amount of albumin that appears in the urine, we try to monitor the amount of albumin that's produced in the urine, and one of our target goals is to try to reduce the amount of albumin that appears in the urine because it's indicative of continuing renal disease. So again, you still got to pee in a bucket for 24 hours. So it's not a great test. And I don't know why we didn't think of this a long time ago. Albumin to creatinine ratios. Okay. So creatinine levels, creatinine, we're going to use that later for measuring GFR. But creatinine appears in the urine. It's produced pretty constantly, so per day you get pretty much the same amount. The only thing that affects creatinine concentration in the urine is the amount of water. And so if you use an albumin to creatinine ratio, that will basically offset any dilutional effects. Okay? So routinely nowadays, you'll get an albumin to creatinine ratio. And what's kind of neat about, medicine does this stuff all the time. So if you measure albumin excretion, you get 30 to 300, 300 plus. And if you tweak it such that you measure it in milligrams per gram of creatinine, the same values come out at 30, 30 to 300, and 300 plus. So in other words, the numbers you get with both those different tests are usually about the same. And so if I get an albumin to creatinine ratio of, say, 30, that's like saying I probably make, or I probably pass 30 milligrams per day. And it's just one of those cute tweaks that they've managed to do. So that's pretty much the standard. Good. All right. At the bottom, this is just a note in advance of what we do tomorrow. Even the actually a lot less than 0.1% of albumin is filtered. You know, it says less than 1%, but it's a lot less than that. That would still be 1 to 4 grams per day, but we do have a mechanism for reabsorbing protein in the proximal tubule. So the amount that appears in the urine is very, very low. Okay? So if you see albumin in the urine, it could be because there's inappropriate filtration, but it could also be that there's inadequate reabsorption of it, because about 97, 98% is reabsorbed under normal conditions. And we'll cover that again later. All right. Protein side. Now this is again, we're on page 5. Yeah, 5. We're going to talk about proteins and filterability. And because this is clinically very relevant, you can be sure that the STEP exam loves questions that relate to what we're about to do. So I'm just going to put some of the Bence-Jones, albumin, and IgG. Bence, Jones, albumin, albumin, and IgG. And what I'm going to do here is the molecular weights. Let's put in the molecular weights: 44, 69, and 150. 69, 50. And relate this to filterability. So the filterability of Bence-Jones proteins, I think it's what, 9%? Is that what's in the handout? 9%. Albumin, I told you it's way less than 1%. It's actually less than 0.1%. And for IgG, which is a lot bigger, it's less than 0.1%. Okay. So what I should have really done was put up the molecular radius, because the filterability is pretty much directly related to the molecular radius. And the molecular radius is only loosely related to the molecular radius is only loosely related to the molecular weight. So, but I just, molecular weights work for me, so that's what I do. So the point is that these get progressively bigger, and as they get progressively bigger, you get less filterability. Okay, Bence-Jones, they're pretty small immunofragments, fragments of immunomolecules, and they're pretty small. And there are certain situations, like in multiple myeloma, where there might be an overproduction of these, and if there's a lot produced, some of them spill over into the urine, and that can cause a proteinuria. As I said, albumin mostly doesn't get filtered, and what little gets filtered gets 99% reabsorbed. So that's just setting up the situation. But now I'm going to put this graph up on the board, and let me make sure I get the numbers in right. I'm putting this graph up and going through it because this graph, this specific graph, has appeared on STEP exams. Okay? And so they think it's important, and I guess I agree with them. So this is filterability. What does it say exactly? Just relative filterability. Filterability. And this is size or molecular radius. And it's measured in angstroms because the chemists still use, molecular chemists still use this unit. Does anybody know how to convert angstroms to nanometers? Wow! They didn't teach any chemistry?
0.1 nanometers.
Yeah, 1 angstroms to this -10.
There you go. Yep. Yeah, there's 10 angstroms in a nanometer. So what have we talked about? So serum albumin has a molecular radius of 3.5 nanometers, which is 35 angstroms. So this is 3.5 and 4.2. 2.6, and we get lines. Dextrans. So we can generate dextrans with different molecular weights, and it's easy to do that. We could also generate dextrans which have anionic or cationic tags. And so in the first instance, that blue line is that pretty close? That's blue. So if we had dextran that had no negative or positive charges on it, at 3.5, it would be about 10% filtered. Does that make sense? Do I need to go through that again? So a dextran, this is the molecular weight of the dextrans. This is a big a small dextran. These are big dextrans. When the dextran molecular weight is such that it's got a molecular radius of 3.5 nanometers, it's about 10 to 15% filtered. Okay? So if you make it negative, and I won't put in the last one, if you tag it with negative charges at the same molecular weights, you find that with negative charges you get zero filtration at a much lower molecular radius. So in other words, despite the fact that it's smaller, it's still not very filterable out here because of the negative charges. Okay? And so from a clinical standpoint, what they want you to know is that, of course, size affects filtration, but also charge affects filtration. So the basement membranes, the glomerular basement membranes, have a whole lot of anionic proteins. And so anytime you have an anionic protein trying to pass through, its filtration will tend to be hindered. And the more anionic it is, the more you'll get hindrance of filtration. Okay? And the reason that this is important is that there are different diseases that affect the charge barrier and or the size barrier of the glomerulus. So if it's a size barrier, well, actually, I think we've got a test here. Okay, let me leave this till we. Let me go through the question in a little while, but just let me leave this at this, that if there's a charge barrier defect, it's not usually very responsive. Did I say charge barrier or size barrier? The charge barrier is quite responsive to steroid treatment. Okay, so if there's a problem with the charge barrier, you can usually fix it with corticosterone type drugs. If it's a size barrier, you're not likely to be able to do it. So you can differentiate the different types of glomerular disease based upon whether it's a charge barrier or whether it's a size barrier. So let's go down to the case, and this kind of amplifies it. Urine protein electrophoresis indicates a high IgG to transferrin ratio. Now, in those days, they used to use transferrin, but pretty much the same size as albumin. So what does that mean? Normally, the ratio for IgG to transferrin or albumin would be extremely small, right? If it gets larger, there's something wrong with the size barrier, yes? Okay. So never mind the biopsy or whatever below, but question, if there'd been no hematuria and the IgG to transferrin ratio had been low, would the biopsy likely show a different result? And of course the answer is yes, because if the IgG to transferrin ratio had been low, that would indicate a charge barrier problem, and probably this patient, you don't usually get this in adults, it's more often in kids, but in this particular case, that would likely be a charge barrier problem, and he might have responded to steroids. So that's why it's significant and important. Okay. See the next page? I try to be relevant and keep up with all the educational changes. This is my de-flipped classroom. Okay, so go ahead and read this. It's tedious to go through it in detail. It's fairly easy just to read. Okay, but what it does is it describes the different types of causes for urine appearing, for protein appearing in urine. I will basically mention at the bottom, though, the note, nephrotic syndrome. This patient we had has nephrotic syndrome. Nephrotic syndrome is a collection of cardinal diseases that share the cardinal feature of proteinuria, massive proteinuria. Okay, so proteinuria and reduced plasma proteins, basically nephrotic syndrome. And I think that's enough said for right now. So let's kind of finish. I think it's the last page. There are a couple of things on this last page, aging and staging. And I won't put all these numbers up on the board for aging and staging, but I think it's obvious to you that there tends to be an aging difference in GFR. So for young people like you, and this is based upon the standard 70 kilogram man on the left, that's 154 pounds. There is no such thing as a standard kilogram man, right? Standard 70 kilogram man. I think the average weight for Americans is now 196 pounds, males. Can you believe that? Wow. So, but the point is that for you between 20 and 29, the GFR is about 128. As you get older, by the time you get into your 80s, your GFR drops drastically to 58. Now, is that kidney disease or is that a normal process of aging? I'll leave you to answer that. Okay. Okay, let's talk about staging of kidney disease. Remember I said that this totally changed back in 2012. And even though you'll get this later, I think it's worth talking about it now. So there are two basic factors. There's protein in the, or albumin, normal. And then there's a creatinine, albumin to creatinine ratio of 30 to 300, which is microalbuminuria. And then there's plus 300. Also, GFR, normal, above 100. And dropping, I think 90, 60, 40, and I don't remember the exact numbers. So it gives you kind of a grid. The point is that even if you have a normal GFR, if you've got any kind of protein, substantial protein in the urine, that's stage 1 kidney disease. If you get, is it 90? 90, isn't it? Yeah. If you get below 90, stage 2. And then it doesn't matter whether you have proteins in the urine or not. If you get below 60, stage 3 kidney disease. And then it goes through stage 4, and eventually stage 5 is end-stage renal disease. Okay, so stage 5 would be certainly less than 30. Is that the number that's given? Less than 15. Okay, less than 15. So does that make sense to you? You have kidney disease if you're producing protein in the urine. And the colors in the diagrams, do you get color diagrams? Yes, you do. The color diagrams basically just, the redness denotes the risk. Okay, so that's what's being used currently. Any questions on what we've done today? Is that the last page? Yep. Any questions? Yes?
For the lecture, do we need to, for the text exam purpose, do we need to memorize all those numbers?
Okay, so I love these questions. So for the test, do you need to memorize all these numbers? Okay, so let me rephrase, let me point out, did I get the numbers right? No, I didn't. So if I didn't get the numbers right, what kind of professor would test you on them? Don't answer that because I don't. Okay, that was a rhetorical question. Okay, so no. In general, I'm not big into you remembering numbers. I think there are some numbers that are worth knowing, like, sodium's usually around 140. But I think that's more of a utility. I will never ask you a question, what is the normal concentration of sodium? I don't expect you to remember those numbers. Okay. All right. Any other questions? Let's go home, have lunch. Oh, I'll be in the office tomorrow between 2:30 and 4:30, 2:30 and 5, okay, if you need me.